Welcome back to Voices for Safety. It's great to be back in the studio with you. Today we're going to be talking about the challenges that people with learning disabilities face when accessing cancer care. People with learning disabilities often find themselves navigating systems not built with them in mind. In healthcare settings, they may face communication hurdles or fail to receive the adjustments that they need, and these missed moments matter. They matter because they add up to something devastating. People with a learning disability live on average 19 to 23 years less than the general population, and nearly half of those deaths can be prevented with the right care delivered at the right time. And then when it comes to cancer care, people with learning disabilities are facing even greater challenges, and that's what we're going to be talking about today. So, I'm happy to be sitting down with Dr. Oliver Kennedy, who is a leading researcher into cancer care for people with learning disabilities. Ollie, thank you so much for coming along to our podcast suite. Can you tell us who you are, what your role is, and what has inspired you to focus your work on cancer care for people with a learning disability?
Sure. So I'm Ollie Kennedy. I'm a medical oncology specialty trainee at the Christie and a clinical lecturer at the University of Manchester. And I have been inspired to investigate cancer care in people with learning disabilities through my clinical practice. When I worked at the Christie, I was always struck by how few patients that we see who have learning disabilities. So you can imagine that we only see patients who've been diagnosed. It's been understood what type of cancer that they've got. Somebody earlier on in the pathway has referred them to us. Who thinks that this person should have treatment, and so we're only seeing a select group of people who've got cancer. And I was very surprised within that group how few people there are with learning disabilities. And so it really made me think, what's happening earlier on in the pathway? Are people with learning disabilities being diagnosed with cancer very late when they're too unwell to be considered for treatment? So when I was doing my breast cancer placement, and at the end of that, I reflected and I realized that I'd seen more men with breast cancer than I had people with learning disabilities. And so it's known that people with learning disabilities do get breast cancer, but for whatever reason, they weren't being referred for consideration of treatment when it's known that treatment is necessary to prevent the cancer coming back or to extend life. So I really wanted to know more about what's happening.
So it's the absence of their presentation in clinically that made you think there's something strange going on here.
Exactly. So it made me think perhaps they're just being diagnosed really, really late. And then at that point, the cancer's too advanced or they're too unwell to be considered for treatment. And I think that diagnosing cancer early is a challenge in everyone, but it made me think it's probably a particular challenge in people with a learning disability because they might struggle to go to the doctor or have the symptoms investigated to the same extent as other people. So that's what made me want to look into this more.
So can you tell me more about your study then? So what did you do?
So we did a study to map out the cancer care pathway in people with learning disabilities. So we included around 180,000 people with learning disabilities and compared them to around 3.5 million people without. And what we found was that people with learning disabilities, they get different cancers to people without. So they more commonly got cancers of the digestive tract, so stomach, esophagus, and bowel cancer. They more commonly got female gynecological cancers too, but then they were slightly less likely to get breast and prostate cancer. We also found that when they went to see the GP with red flag symptoms, they were less likely to be referred for specialist testing. And then that led to them being diagnosed much later. They were more commonly diagnosed on the date of their death when cancer was the cause of death, or diagnosed after the cancer had spread when it can no longer be cured. And then they were also less likely to receive treatment. So around 50% less likely to receive treatment within 6 months. And then because they didn't get treatment, their life expectancy was also much shorter. It was around half of what it is for people without learning disabilities.
So when you compare them to people without a learning disability, what are you comparing them to? Is it just anybody without a learning disability, or are there certain variables, as we would call them, that you compare them to?
Yeah, so in these studies, bias is always a risk, and so to try to minimize that, we wanted to keep the two groups as similar as possible. And so that they only varied by the fact that one had learning disability and the other didn't. So we started with the people with learning disability, around 180,000 of them, and then we matched them to comparators by the same age, the same sex, and from the same GP practice, so that we were trying to sort of make sure that the comparison was fair.
I can't imagine, with all the information that we know about the inequalities that people with a learning disability face socially and in the healthcare system, I can't imagine this is terribly new stuff. So what was it about your study that made it different to what we already know, and what is it that we already know?
Yeah. So before the study, we already knew that there were some differences in cancer care. So we knew, for example, that people with learning disabilities were less likely to participate in national screening programs. So in England, there's currently 3 main ones. There's the bowel cancer screening, breast cancer, and cervical cancer. And we know already that people with learning disabilities are less likely to take those screening tests. And then we also knew that they tended to be diagnosed a bit later. So what we wanted to do was to see whether we could replicate those findings on a much bigger scale, but then also try to find out why those things were happening. So one of the interesting things that came out of our study was the risks of the different cancers. So the most common cancers in the general population are breast cancer, prostate cancer, bowel cancer as well. And what we found was that the types of cancer that people with learning disabilities get tend to be a little bit different. So the most common cancers were the digestive system cancers, so the bowel cancer or stomach cancer or esophagus cancer. But what was less common were breast cancer and prostate cancer. So the people with learning disabilities still got those cancers, but not to the same extent that other people did. And so it just highlighted how our whole approach to cancer care is based on the sort of average person, and that doesn't really apply to people learning disabilities. And then what I mentioned before was that it was already known that that people with learning disabilities tend to be diagnosed later, but it wasn't really clear, is that just because they don't go to the doctor, or is it because they're going and the symptoms have not been looked at? And so what we found was that they were actually going to the doctors with these red flag symptoms. So symptoms that might make you think, does this person have cancer? So that would include things like bleeding from the back passage, or difficulty swallowing, or a lump, that kind of thing. Yeah. And what we found is that they were just much less likely to be referred to a specialist for investigation. So it did seem that there were missed opportunities along the diagnostic pathway.
Is there any insight into the answers to that, into why that has been, or is it just purely looking at the trend?
Well, I think it's tricky to say, because being a GP is really difficult. So they get often 10-minute appointments. That's hard for anyone, but you can imagine it's particularly hard if you're seeing someone with a communication difficulty. There's also that thing called diagnostic overshadowing, which is where somebody might come with symptoms because of cancer, but then those symptoms, instead of being investigated from first principles, they're just attributed to being part of the learning disability. So something like that might include, if someone goes with blood in the urine, which is a sign of prostate cancer, instead of thinking what's the underlying reason why this person has blood in the urine, could it be prostate cancer, they might just instead be treated for a urine infection without being investigated. So that was something. And then the other thing is that just our healthcare system, it relies on a degree of self-advocacy too. So if you take prostate cancer, for example, there's no screening program in the UK at the moment, but any man can go and ask to be tested for prostate cancer, which is all well and good if you're aware of the fact that you can ask for it and you're aware of prostate cancer. But if you've not, that system isn't likely to serve people with learning disabilities very well.
Yeah. Or a lot of men, I suppose, if they
exactly.
don't know that message is out there and they don't know what they can ask for. We've talked a lot about the sort of front end of the cancer journey when someone's attended their GP practice. But what did your study find about that sort of latter end, so referral onwards, and then any outcomes or time to treatment?
Obviously, yeah, I think treatment is really important, because even if you diagnose it early, in order to extend someone's life, then you still need to be able to treat them. And what we found was that when they were diagnosed, it was often metastatic or advanced cancer. And so once cancer spread beyond where it started, then it's harder to cure. So the treatments are less effective in that setting. But in any case, they were just much less likely to receive treatment. So, and that was across all the different stages. So whether it was diagnosed early or diagnosed late, people with learning disabilities didn't receive treatment to the same extent. So they were around half as likely to get treatment within 6 months of diagnosis compared to other people. So then that again was reflected by the fact that they were then much more likely to die from the cancer that they had. And so if you take all the cancers across the study, the average survival for people without learning disabilities was around just over 9 years. That was for people without learning disabilities. For people with learning disabilities, it was less than half that. So they were living for a much shorter time. And then one of the other interesting things was if you were able to diagnose cancer early, then the treatment differences between someone with and without learning disabilities were much smaller. If the cancer was diagnosed late, then the treatment differences were huge. They were up to 85% less likely to receive treatment if the cancer had already spread. So I think there's a benefit of early diagnosis in everyone, but particularly in this group, because it seems that once it's spread, it's very difficult to treat them.
That's quite a stark finding, isn't it? That people seem to be treated differently all across the cancer care pathway.
Exactly, yeah. So in my work as a medical oncologist, so I would typically give someone chemotherapy for cancer, and it's quite a complex procedure to do that. So you see them, you've got to explain the risks and benefits of the treatment. You've then got to do blood tests. You have to get them to consent to say that they understand all the risks and benefits and that they agree to treatment. They then will come in for a dose of chemotherapy and then go home typically for a few weeks and then come back again for the next cycle. And then during that time, the patients have to call the hotline if they start to feel unwell because there's a risk of sepsis and things like that. And so all those systems are not well set up for people with learning disabilities. So, for example, as a medical oncologist might feel very nervous about giving somebody chemotherapy if there's any doubt whatsoever that they might not call for help if they don't feel well. Because one of the most common side effects of chemotherapy is infection, and then that can lead to sepsis. And in sepsis, there's that golden hour where if you can give antibiotics within the first hour, the risk of death is so much lower. And so those kind of delays lead to sort of nervousness and hesitancy for people to treat people with learning disabilities. So that's something where more work is needed and potentially some sort of reasonable adjustments along the pathway so that treatment can be safely delivered.
What do we do about this, Ollie? Apart from the reasonable adjustments, what can we do within the health system to ensure that there's that sort of equity of treatment and equity of access for people with learning disabilities?
Yeah. So I think it's tricky because you've got problems all along the cancer care pathway. So I think in the pre-diagnostic setting, I think we need to think about the cancer screening programs and why they currently don't serve people with learning disability as well. So one of the key findings from my study was that people with learning disabilities are around about twice as likely to develop bowel cancer before the age of 50. Now, in this country, the screening program for bowel cancer only begins at the age of 50. And so there's an argument to be made that people with learning disabilities should be screened for bowel cancer from a younger age. And that recommendation has been made in various different reports. But currently there's a lack of evidence of cost effectiveness of screening at the younger age in that population to actually make a difference. So I think that there's definitely a need for further work to look at adjustments to the current screening program so that they better serve people with learning disabilities. I think in terms of the referrals, when somebody goes with symptoms, I think GPs always need to sort of think, particularly if someone's been back a couple of times with a similar thing, to think whether or not there could be something else going on. And I always say, to any patients, you can ask your GP at any point, could this be cancer? And I think, that will always prompt the GP to think about it explicitly and to, do any investigations that might be merited. And then there's the treatment differences. And so I think that's something that I've got an interest in and I've applied for fellowship for. And so what I'd like to do is to see, as a medical oncologist, are there any adjustments we can make so that we can safely offer chemotherapy and similar treatments to people with learning disabilities, more than what we are now. So my study shows that people with advanced bowel cancer, so that's bowel cancer that's spread beyond the bowel to other parts of the body, the 80%, 85% less likely to receive chemotherapy than people without learning disabilities. And at that point, chemotherapy is really, or similar treatments are really the only thing that can extend life. What I showed in my study was that if someone with a learning disability is diagnosed with advanced bowel cancer, then they only live on average for about 6 months, which is around about a third of what other people live for, which was about 1.5 years. There needs to be changes all along the pathway from diagnosis all the way to treatment. And then the other thing is as well is about the risk of cancer. So what my study showed was that cancers that are related to obesity, so you could say bowel cancer, esophagus cancer, stomach cancer, as well as some gynecological cancers.
Cancer.
So uterine cancer, those cancers were much more common in people with learning disabilities. And when you look at the risk factors that people with learning disabilities are exposed to, you see that they tend to have less exposure to things like alcohol, but much greater exposure to things like obesity and poor diet, lack of opportunities to exercise. And so there needs to be a public health approach too, because they say prevention's better than cure. And if the preventative strategies can be improved in this population.
Absolutely. It sounds like there's a lot of things that we can do from multiple areas within the health system and within health research. Is there anything that people with a learning disability can do their end? What can they do to ensure that their voices are heard better?
Yeah. I mean, I definitely preface this by saying that it's a responsibility of the medical professionals and the system that they see to make sure that diagnoses happen in a timely manner. But I think, if somebody is going to see the doctor, or they're taking a family member to see the doctor, and they're going back with the same problem again and again, and they don't feel that there's been an underlying reason found to explain that, then I think they can ask the question, could cancer explain the symptoms that they've got? I mean, I'm quite hesitant to kind of give that advice, because when we published our study, we co-presented the findings with MenCap, and there was a lady with a learning disability who gave her story on Sky News, and essentially she described how her cancer was missed, and I think she'd been to the doctors, and it had been explained as other things, and things. So it is incredibly difficult for people with learning disabilities, and I think it's got to be both sides. So the doctors, the system, and I think that's where the main change needs to be, really.
So what would your recommendations be then for change?
I think the cancer care pathway is very complex. So and it consists of lots of different kind of like components, and so there's no one change that's going to fix all the issues. I think you could divide it into prevention, screening, diagnosis, and treatment. In terms of prevention, then as I say, there needs to be some public health approach that addresses high rates of things like obesity, sedentary lifestyle, poor diet in this population. I wonder if they're getting, for example, the same access to the weight loss jabs that other people are, because again, that's a similar thing, that people might be hesitant to treat them with the weight loss jabs because of concerns over side effects, and that might be an overly cautious approach that means that they're not benefiting from those kind of public health strategies that other people are. In terms of the diagnosis, then I think there should be potentially a separate pathway for people with learning disabilities who potentially have got vague symptoms that don't fit into any of the existing 2-week wait referrals. So at the moment, for example, you would go with a breast lump, you get referred to the breast clinic. You go with difficulty swallowing, you get referred to the to the upper gastrointestinal clinic. And I think sometimes it's difficult for GPs if they feel the symptoms don't fit into any of those boxes. And so I think that there could be a separate pathway where more vague symptoms could be investigated more easily. And then I think for screening, there needs to be more investigations done to see whether or not, in particular, the lower age of onset of bowel cancer in this population could be screened for in a different way. And then I think the treatment issue as well is huge. And I think all the different modalities of treatment, you have surgery, radiotherapy, systemic therapy, so chemotherapy and similar drugs. Each of those probably needs a separate solution because the challenges for each are different. So I think we just in a way need more people looking into it because it's a huge population that we're talking about. So in England, around 1.5 million people have a learning disability. So it's an awful lot of people that are affected. So you could actually make a huge difference by addressing some of these issues.
It's wonderful to know that they have people like you already within the system advocating for them and trying to unpick these really challenging areas and trying to make the system better and safer for those people. So thank you very much for coming along today and talking about your extremely important research. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, Blue Sky, LinkedIn, and on our website www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights, innovations that make healthcare safer for everyone. Thank you all for listening, and we'll catch you in the next episode.